Welcome to this afternoon's webinar, Cannabis and Pregnancy. Today we're delighted to have Justin Gleeson with us for our webinar. Justin is the clinical specialist midwife for substance use and alcohol. And Justin is part of the Drug and Alcohol Service within the HSE in Community Healthcare West. So Justin, thank you very much for being with us. Justin has done webinars for us previously on other pregnancy related issues such as cocaine and alcohol, and we're delighted to have him back here today for cannabis use and really interested to hear what Justin has to say in relation to this. Justin will also give you a little bit of information in relation to the service that he provides here in the Western region. So over to you, Justin, and thank you.
Thanks very much, Orla. I appreciate it. Yes, so Justin Gleeson's my name. I'm a clinical midwife specialist with the HSE substance misuse team here I cover the maternity services of Galway, Mayo, Roscommon and Sligo at present. Our kind of role, we're called drug liaison midwives. We were founded back in the early 90s. There was three of us based between the three Dublin maternity hospitals in the Rotunda, the Coombe, the National Maternity Hospital. I was working in the Rotunda for 17 years. Our primary role back then was to really look after the specific needs of heroin users and those who are on methadone maintenance. And we see a kind of a general change in the demographic of substance misuse in general. With that then became the expansion of our service to incorporate other substances, and then in 2019 the service then kind of went nationally. I was working in CH05 covering the maternity services of Wexford, Waterford, South Tipperary and Carlow, Kilkenny, and then 2 years ago then moved here to the west. The topic today then is cannabis use in pregnancy. And this has been quite provocative, I think. I mean, if you go back to the times when I was working in the Rotunda, I would say back in 2007, where you'd have 120 women referred for opiate misuse. Obviously, the priority really was given to the women with those specific needs. So people who were referred to us with cannabis use, it was we often didn't really take those referrals. So what we're going to go through today, is we're going to discuss cannabis, its origins and its prevalence, and we're going to discuss cannabis use in pregnancy and how things have changed from back when I was started in 2007 to today. And then we're going to discuss cannabis use in breastfeeding, which is also quite can be quite controversial. There's a lot of controversy in relation to that too as well. We're going to look at treatment options, and we're going to look at a couple of case studies, maybe to kind of bring things together. I only formulated this in the last couple of days, so I mean, and even the process of doing that, I've learned a lot in the process myself. So hope you get something from this. So cannabis, the street words we'd use is dope, puff, weed, blow, draw, shit, spliff, pot, grass, marijuana, skunk, hash, hashish, wacky tobacco, and snowbar. It's made from the heads of and flower of hemp, a plant called Cannabis sativa. It probably originated in India about 8,000 years ago, and Afghanistan is still currently the largest exporter of cannabis in the world. So cannabis plant matures in 60 days indoors and 3 to 5 months outdoors. I suppose hence why it's so popular that it's grown in grow houses, so you get a bigger yield. So the dried flowers is your cannabis herb, and the compressed resin is your hash, which would have been quite popular when I was in college. It was very, very difficult to get herbal grass. And then you'd have the THC extract, which is in your oil. There's over 480 natural components found within the cannabis plant, and 66 are cannabinoids, and these are the chemicals which are unique to the plant. And I suppose because there's so many different kind of components to cannabis, I suppose isolating its cause and effect, isolating all the variables in relation to its cause effect specifically to pregnancy has been proven quite difficult. The main psychoactive agent is a delta-9 tetrahydrocannabinol, or THC, and we'll just refer to it as THC rather than using the whole big word. There's three classes of cannabinoids. You got CBG, CBC, and the one we all know is CBD. And these are not psychologically active, where the others, including THC, CBN, and CBDL, are. So the different modes of cannabis delivery. Well, the main one we all know is by smoking, and then use then by using the new cannabis vapes. I mean, like or bongs as well. We use as well. So the onset is that you normally you get your hit about after about 1 to 2 minutes, and the duration is about 1 to 3 hours. The oral drops or the lozenges and or the sprays and the gummies. I mean, like these, the onset is normally 10 to 50, 25 minutes, and again lasts for 1 to 3 hours. The ingested capsules and the edibles, and like your cakes or your muffins and your drinks, the onset is usually about 30 to 90 minutes, and the duration is a lot longer, between 6 to 8 hours. The topical balms are about 15 to 30 minutes and with the duration of 3 to 6 hours. The transdermal patches and the gels, 15 to 30 minutes and 6 to 8 hours. And vaginal and anal suppositories, which I never really heard of before in relation to cannabis, but seemingly there are, which the onset is 20 minutes and lasts for 3 to 6 hours. So what does cannabis actually do? Well, the short-term effects of cannabis, well, I suppose the real main reason really, you're feeling sedated, chilled out and happy. But also like, you can get quite dizzy and can feel quite sick. You have a feeling of hungry or getting the munchies. Your heart rate speeds up when your blood pressure goes down. You have very, very, very dry mouth, and you feel quite tired, and some people can have bloodshot eyes. In the long term, may damage your lungs and lead to breathing problems, has been linked with mental health problems such as depression and schizophrenia, may lower sperm count and suppress ovulation. So getting pregnant may be more problematic. And I suppose this would be quite poignant for when we're giving preconceptive advice. Regular use may affect your memory, your mood, your motivation, and your ability to learn, and may cause anxiety and paranoia. They may affect coordination and reactions, so you're more at risk of accidents, especially if you use it with alcohol and with other drugs. So potency throughout the years, and I think a lot of this, I mean, going through the research from what we would have had in the 70s to what we have now, it is slightly different because we're seeing now that the cannabis today contains more than 10 times as much THC on average than it did in the 1970s. So I suppose what's out in the market there today is a lot more potent than it would have been in the past, especially when I started off really in 2007. According to the Healthy Ireland survey in 2022 and 23, 1 in 5 people, 20%, reported using cannabis at least once in their lifetime. Lifetime cannabis use is more common in men, 26%, than in women, 15%. And also among the younger age groups, as 31% of those aged between 15 and 24 have used cannabis compared to 4% of those at 65 years and over. 6% of respondents in the study reported using cannabis in the last year, with 3% using cannabis within the last month. The prevalence of cannabis use among pregnant women and lactating individuals in the US ranges from 3.9% to 16%, and that's Hayes et al. And a US National Survey on Drug Use and Health found that 5% of pregnant respondents reported any cannabis use compared to 2.43% in the UK. And this is all self-reporting, so it's probably not that accurate. So the big question is cannabis safe in pregnancy or not? And this is a slide that I did I used in the presentations, or well up until maybe till 2013. What I said in this one was that information on the effects of cannabis use in pregnancy are generally poor. And a review by of cannabis by the WHO in 1997 concluded that there was no good evidence that cannabis itself has a direct effect on pregnancy or the baby. And the main message back in those days was that cannabis was normally mixed with tobacco and smoked as a joint. And it was the tobacco that contributed to the reduced birth weight, the increased risk of sudden infant death syndrome, and many other pregnancy complications. So this is where we were, and I suppose this is what I suppose the grounding really of the confusion around the whole area about its effects in pregnancy. There's a lot of myths about cannabis use in pregnancy. It's natural. So a lot of people say it's natural, so it's safe. Smoking is bad, but other forms like edibles are safe. And cannabis can be used to treat morning sickness or other conditions. And I would get this a lot in a lot of girls who are trying to validate their reasons for continued cannabis use in pregnancy. It's only just literally this last week. I mean, I met with an individual who was able to cite research, albeit outdated, trying to confirm their position as the reasons why they were going to continue cannabis smoking during their pregnancy. Um, an analysis of the National Survey of Drug Use and Health from 2007 to 2012 demonstrated that 70% of pregnant and non-pregnant females believe that there is a slight or no risk of harm from using cannabis 1 to 2 times per week. And 69% of pregnant women in Colorado cannabis dispensaries are recommended cannabis to alleviate morning sickness. And I suppose that's only, I mean, you have to look inside in Canada, cannabis is legal. And I suppose if you're going to go to one of the dispensaries, of course they're going to say, well, you know, it's a legal drug. I mean, of course it's going to help you in relation to your morning sickness. Sure, don't we give it to people who are on chemotherapy for their sickness? So it's trying to make these comparisons. I think is that when we look at this, we need to go back to how far we've come from alcohol. And if we look back then out of all the substance of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects of the fetus. That's the Institute of Medicine report Congress in 1996. And we knew that alcohol was a teratogen in 1996. So then I've taken this from a maternity information pack of a well-known Irish maternity hospital. I'm not going to name it. But in this section, is that we recommend that you should not drink alcohol during pregnancy. Even moderate drinking can harm your baby. However, taking 1 glass of wine with the meal every so often is not unreasonable and has been shown not to harm not been shown to harm the baby. And that goes from 2010 to 2015. So you can see how sometimes these mixed messages can create general confusion within the population. So I suppose really it's the perceived benefits and perceptions that perinatal cannabis use is safe and may underline the increase in prevalence. However, these beliefs and perceptions are nuanced and have been influenced more by their personal experience than information received about its risks. So the education addressing pregnant women's desire for credible, evidence-based information on perinatal cannabis use is crucial to inform decision-making and mitigate potential risks. Okay. So what are the effects in pregnancy? So a prospective study done by, I can't even pronounce that et al. In 2020, compared with babies of mothers who have never used cannabis, infants of those who still use cannabis at 15 weeks had lower mean values for birth weight, head circumference, birth length, and gestational age of birth, indicating that continuous cannabis use in pregnancy is an independent risk factor for poorer neonatal outcomes. So we look at fetal brain development. In utero exposure to THC has been found to impact fetal brain development, including the interruption of normal brain maturation that may increase the risk for later life neurocognitive and neuropsychiatric disorders. And these are a recent study by Nasheed et al. In 2021 in relation to that. Preterm birth, cannabis is associated with preterm delivery. Many studies have consistently reported that prenatal cannabis use is associated with an increased risk of preterm birth, defined as delivery prior to 37 weeks gestation, even after adjusting for confounders such as tobacco use. So, I mean, and as I said, it was a big, massive mix over. Is it linked to tobacco use on its own? Where now we see that, you know, the mixing of tobacco is going to change, and we're seeing a lot of women presenting who are just smoking cannabis grass only without mixing it with tobacco. And that's that says 2026. Actually, my apologies. It couldn't be that quick. That's actually 2024 by Gunn et al. Apologies about that. So then there's also then the whole phenomenon of neonatal withdrawal with cannabis, and even back as in the in late in 2010, I was beginning to see babies manifesting signs and symptoms of neonatal withdrawal from cannabis exposure. So maternal cannabis use has been associated with withdrawal-like syndrome in newborns and increased aggressive behavior and attention deficits in offspring as early as 18 months of age. And though that research is going back to 2014 and 2011, so that it has been marked. I think the big thing that what I would have seen in earlier studies was that the effects of the in the neonate in the immediate after delivery in relation to neonatal withdrawal was a lot more apparent for cannabis use rather than some other drugs. So then we go to then breastfeeding. Research on how marijuana is used by breastfeeding mothers affects infancy is even more limited. A prior study found that THC concentration are 8 times higher in maternal milk relative to plasma, and infants are exposed to 0.8% of the mother's consumed a single dose in a single feed. As THC is highly lipophilic, it can be inferred that THC may be stored in the infant brain tissues, which can have long-term effects on neurodevelopment. So I suppose really is that we do know that it does attach to the fat cells, that it does transgress through breast milk, and it is stored and can be stored in babies for up to. I mean, babies can continue to test positive for cannabis for those who are still actively breastfeeding. So it only stands to reason that this THC can have effect. However, we don't necessarily, as I says, the data is limited, and it's only beginning to. I mean, like it's very, very, very difficult to get ethical approval to do studies on neonates, and even for pregnant women who are taking illicit substances, including cannabis. A systematic review evaluating the safety of marijuana use while breastfeeding found that human and animal studies providing evidence supporting concerns about the risk outnumber those finding no concerning evidence. So I suppose in the absence of a definitive evidence that it poses no health harms to infants, health organizations typically recommend a conservative approach to avoiding use while breastfeeding. And I think this is the big thing for me in order to create an incentive for women to stop using cannabis, especially for those who wish to breastfeed. And we're seeing lots and lots more women now opting to breastfeed now. So I mean, like so sometimes it can be we can focus it becomes the primary focus on how to maybe addressing their cannabis use during the course of their pregnancy and hopefully stopping it prior to their delivery. A new kind of phenomenon that I've only really learned about in the last couple of years is a condition called cannabinoid hyperemesis gravidarum. It's a health condition that has gained recent recognition after it was first described by Allen et al. In 2004 as a cyclical vomiting illness induced by chronic cannabis use in which symptoms were relieved by hot water bathing. Uh, Early diagnosis and cessation of cannabis use are crucial to prevent complications like severe dehydration. I have, over the years, I've seen more and more women who are presented to our ED departments with multiple admissions for hyperemesis. And then, I mean, especially those who were smoking quite large amounts of cannabis. And this is, I mean, it's something that I saw when I was inside in the Rotunda, and again in the southeast. And we're going to go through one of the case studies as well in relation to how we manage that. But like, but the key factor here is in trying to diagnose it. A lot of women, who are who would have this condition would say that the only thing that helps relieve their symptoms would have been the cannabis itself, not knowing that the cannabis was the actual cause of this extreme form of nausea and vomiting. And it's only when they stopped using after a certain period of time that all the symptoms went. But it's really, really difficult to get to that stage, and we'll discuss that later. So how might you help? And I know there's a good few midwives here as well. And I think the big thing really is that when we find out The booking visit is a very, very, very valuable time in which you're trying to elicit information from the mother in whatever maternity hospital that she attends. And the big thing is really is trying to create an environment in which she's able to engage with you and is able feels confident to be able to disclose this type of information. And I think it's really important that we express empathy. We ask open questions. We find out what exactly it is that she wants to do. Because, like I said about the other lady that I only met 2 weeks ago, it was very, 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 very clear from her perspective and her partners that there was no way that she was going to reduce her cannabis use because of the information that she had at that particular time. So I suppose in such situations, and this will happen in like from time to time, it's very important that we highlight the medical concerns as a brief intervention, and we offer the options whether it's we got Marijuana Anonymous. If there was a maternity units, refer to their drug liaison midwife, and who then would in turn then offer supports and linked with the substance misuse teams in that area. So we start. You have to start somewhere, and I think the what we call is reducing the level amount of harm. So the harm reduction tips. Obviously, we want someone to stop, and that's the whole objective. But then you have to start somewhere. So it's about we stop using. I had to ask them to start cutting down their cannabis use from as soon as after our first initial assessment. Um, Simple tips like don't smoke cannabis with tobacco, because we have a whole catalogue of information in relation to the dangers of carbon monoxide and tobacco use in pregnancy. Avoid inhaling too deeply. Traditionally, I mean, like a lot of people would smoke cannabis would hold it in for a very, very long period of time until it's absorbed in the lungs. So we'll ask people we advise them not to do that, to avoid holding smoke in the lungs, to use less cigarette papers, don't use plastic bottles, rubber pipes, PVC, aluminium oil or foil. We get them to use filter rather than using a roach as a filter. We use a very, very low tar tobacco if possible. Avoid sharing joints, very important in relation to potential viral transfer. Um, Clean weed it properly. And I got to some of this from a friend of mine who we say is in active recovery, and and he said that I was asking him what you mean by clean the weed properly, and he said, well, you normally take some of the bits of wooded pieces, the sticks and so on, and other kind of impurities that may be in cannabis grass that may like that would have gotten dirty over during its transfer or whatever. We've got use of cigarette filters, if possible. Clean the bongs, if those who are using bongs and pipes properly after use, because they can build up and maybe would build up with different types of bacteria which you inhale into your lungs as well. This is all about reducing harm. Uh, um, don't buy large amounts together, and I suppose that's a big thing. A lot of people will go out and maybe spend maybe about 150 euro at one time and use it maybe throughout the week. And we're asking, the idea is about trying to use their finances a little bit differently, and rather than bulk buy, I mean, like try to separate it out so that it kind of it induces an incentive to help reduce their use. An important really to have cannabis-free days, and that's trying to introduce the whole idea of not using cannabis for certain either certain periods in the day where they would have done regularly, or having cannabis-free days to kind of introduce the whole idea of getting of gradually stopping. Wait until the next day to use, same thing. If you're using with others, use in a place you feel at ease and with people that you're comfortable with. I mean, like, especially, I mean, like, for those who may have stopped for a period of time and their tolerance has gone down and they use large amount and they could be putting themselves in a situation where they may not be safe. So the treatment options for cannabis problems. Well, motivation and enhancement approaches, and I think is that I mean that's basically what I would use quite a lot, and we use some cognitive behavioral therapy as well. Family therapy based interventions can be quite good when we're using other family members, especially when they're actively involved in the pregnancy itself themselves. Whether you could have a partner who's actively using as well, and sometimes it's good to maybe to include both. And as you know, because obviously the risk of relapse is more tempting if the other partner is still actively using. Um, for the hyperemesis, the cannabinoid hyperemesis gravidarum, I would use the pregnancy unique quantification of emesis. It's the puke score, and this is a score that we use to a chart. We score points to use to rate nausea and vomiting in pregnancy, with the following with very similar to like a Finnegan score, with the classifications can either be mild, moderate, or severe. It's great to be able to if somebody has reduced their cannabis significantly, or more importantly has even stopped, that they've actually you're able to quantify the marked difference in their, I suppose, in their physical appearance, and and certainly being able to measure how often they've been sick since they've stopped, and they see the benefits themselves. And it's a great motivation really to remain off cannabis, especially in the postnatal period as well, where somebody would feel, okay, I've gotten through the pregnancy now, I've stopped now, and I intend to go back smoking pregnant cannabis once the baby's born. So, in the case studies, I got two case studies here, and I'm sorry, kind of probably must have flown through this other stuff, but this kind of gives you kind of an idea of what we've just discussed. So we've got Jennifer, a 23-year-old first baby. She was referred to me by the opiate substitute service, a provider in the southeast, and she transferred from the southeast to Mayo University Hospital, and she had a history of benzodiazepine use and cannabis use. She stopped all the benzos, but she continued smoking cannabis due to nausea and vomiting. And what I mean by smoking cannabis, she smoked a lot of cannabis. I mean, she would use maybe up to 50 to 60 euros a day, easily. And she would come into a room with me, and the room it would be quite pungent. I mean, it would be very, 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 it was literally coming out of her pores. But she really, really tried. But the nausea and vomiting that she had multiple admissions to Mayo University Hospital, with hyperemesis. She was put on Caraban, she was put on Stemetil, all types of antiemetics. And the thing I knew we were making the link was that none of the antiemetics were effective. The only reason why she was admitted is because it was for dehydration. So she'd go up on an infusion, and then once then she felt anyway half decent, she was discharged, and she'd be literally in nearly every week. So going through her case and the cases I would have seen in Dublin was came quite clear to me that she had this condition called cannabinoid hyperemesis syndrome. And the biggest focus for me really was to try and meet with her and to help her try and make the relationship, see the relationship between her cannabis use and her hyperemesis. But for her, she said that without cannabis, her hyperemesis would be like 10 times worse. And she met this psychological link between her symptoms being alleviated through cannabis. So rather than her cannabis use decreasing, it increased, and as a consequence, her admissions to hospital with hyperemesis increased also. It's only kind of really when we got to coming up to her third trimester that she took an active approach in trying to stop, and she did stop. She reduced over a period of 2 to 3 weeks and then stopped, because what happened was is we were focusing more, so she was really, really determined to breastfeed. And we were making the link between the potential hazards to her baby of breastfeeding while still actively smoking cannabis. So then when she stopped in her third trimester, all our symptoms of hyperemesis just literally vanished. And I think is that, and even for me as a practitioner to actually see it, was, I mean, it was quite remarkable. I mean, like to see how actually sick that she actually was compared to how she was in her third trimester. Her puke score went from severe, quite severe, to mild. I mean, if not even zero. She went on to deliver a live born baby female. And she moved back to the southeast, and I referred her then to the supportive services then inside in the southeast. And I think that's the one thing about our job really as drug liaison midwives. We all work collectively together throughout the country. So I think is so for the likes of Jennifer, would say, with an real name, but which got like to link her up with our other colleagues in another area throughout the country, I think made her recovery, it continued that, which got, and there was kind of no break in her care. And I think, from what I understand, is that she continues to do really, really well, for my colleagues there, even to this day, which is very encouraging. So then we have another girl, Carla. This is slightly different. 32-year-old, Gravida 2, Para 1. She was referred by my colleagues in Galway University Hospital. She smoked cannabis since the age of 16, from when living in Brazil. So, I mean, this would have been a kind of a cultural norm. She explained it to me anyway. Um, at the start, she was very reluctant to stop using cannabis as it helped with her, as she used it to help her with her anxiety. It was kind of her reward in the evening, during a hectic, stressful day, for her to unwind, and just became part of her normal routine. The big thing about Carla is that she didn't breastfeed in her first pregnancy, but she was determined to breastfeed this time because she wasn't planning on having any more children, and she had engaged with antenatal classes and had to understand the benefits of breastfeeding. But like that, she also presented to me data that also would have that have contraindicated the data that we have, trying to saying that that minimizing the risks of breastfeeding, sorry, minimizing the risk of continued cannabis use while breastfeeding. So I had regular appointments for her in her local primary care unit, focusing on motivating interviewing, focusing more so really on the benefits of breastfeeding without cannabis and the dangers of cannabis use in while breastfeeding. And I think this became her biggest focus, and she began to reduce her cannabis use quite significantly. And coming right up to the time when baby was born, she had stopped using cannabis. She had a live born female, and she remained an inpatient of 120 completed hours. And that was really just to kind of observe for any kind of obvious signs of neonatal abstinence syndrome, which there wasn't any. So she was discharged, and it was because it was her first time breastfeeding as well. I linked it quite closely with her public health nurse out in the community, and I suppose together she continued to do quite well. I don't know. I mean, like, it's. I mean, like, when she was discharged from my service, she was still not smoking cannabis, and had done really, really, really well. So, and it was kind of another positive result. But I'm not naive. I mean, like, I mean, it's. I mean, I don't know if she's still actively smoking, not or not. But I think that certainly during the whole process of the pregnancy itself, that she'd gained an awful lot and knew herself that she was able to, to manage without smoking cannabis, especially to help to deal with issues such as her anxiety. Okay, that was kind of that's all I have, which for you on this topic. It's it's an evolving one. I mean, like, with new papers being churned out nearly every couple of months or so. The whole issue of the cannabinoid hyperemesis gravidarum, we're hoping to do kind of a combined study between our all drug liaison midwives, combining our data together to see this growing phenomenon, and hopefully be able to publish something soon. So